Good. Firstly, I'd just like to thank the organisers for this really amazing opportunity to speak at this event. And I'll just be sharing some of my thoughts about this question, what do gay men need for effective HIV prevention? This is an issue that's very close to my heart. I started in this profession as a community educator and then moved into research, and I'm also an out and proud gay man. So it's a very important topic for me. So I'm going to be looking at three main questions here. Very briefly, why do we need effective HIV prevention? Andrew and Nitya have already foreshadowed a lot of that. What is effective HIV prevention for gay men? And then the bigger question, what do gay men need? And I'll just be considering a few different factors there. So why do gay men need effective HIV prevention? Look, we know that HIV prevalence is high in many countries around the world for MSM and other gay men, and it's typically much higher in MSM and other gay men than it is in the general population. And overall, the epidemic does appear to be worsening. Even in countries that have generalised epidemics, we can see that the HIV prevalence among gay men is generally higher. And although some places in the world are seeing declines, like San Francisco, in diagnoses in gay men or stability, as is the case in the United States overall, many places in the world are seeing these big increases in prevalence amongst gay men. And this has been true all over Asia, as you can see on this slide, and also in the UK and in Australia. But although, as Andrew just said, in the last few years we have seen more stability in the Australian context. So of course, HIV prevalence can increase when you increase the number of people on treatments and you increase testing. So this slide shows incidence data from a number of places around the world, with very high incidence rates being recorded in China, Kenya and others. And while this graph is a little bit confusing to look at, basically the main message here is that incidence is increasing in many places in the world, and that's despite the massive increases in ART uptake and HIV testing that have occurred in many locations. So I hope we're all in agreement that gay men need effective HIV prevention. So what is effective HIV prevention for gay men? In the past, the concept of safe sex was synonymous with consistent condom use. And in many places, and particularly early in the epidemic, the condom use message was promoted universally for all sexual partners. However, we now know that some forms of condomless anal sex can be considered safe sex. In terms of treatment as prevention, we've seen that in the analyses presented so far in gay men, there have been no linked HIV transmissions within homosexual male serodiscordant couples in either the partner study or the opposites attract study of treatment as prevention. And also please look out for the final results of the opposites attract study, which should be coming out later this year. Similarly, in terms of PrEP, several studies, as Andrew's mentioned, have now shown its high degree of effectiveness, provided that men take at least 4 pills per week. And AVAC estimates there's more than 50 demonstration trials on PrEP underway in the world at the moment, so we're going to have a lot more data over the coming years about that. In the combination prevention era, HIV testing is increasingly being seen as an important gateway to effective HIV prevention, given that knowledge of one's own HIV status is necessary to initiate ART, access PEP or PrEP, or engage in non-condom-based risk reduction strategies. So research indicates that HIV-positive people who are not aware of their serostatus contribute disproportionately to new HIV transmissions, and they tend to engage in higher risk behaviour than those HIV-positive people who do know their status. So clinical guidelines in many countries recommend at least yearly testing for gay men and then up to 4 tests per year for higher risk gay men, which usually means condom-saline intercourse, high partner numbers and drug use using sex. However, in most locations, HIV testing frequency is much lower than is recommended by these guidelines. For example, in New South Wales, although the situation is improving around testing frequency, the majority of these high-risk gay men are still not tested frequently enough. So where we once relied just on condoms as our main prevention tool, we now have a much greater range of prevention tools. And so they sort of can be broken down into different categories of reducing the infectiousness of HIV-positive people, preventing the exposures, and also reducing the susceptibility of negative people. So the main part of this talk will be focused on these some factors around what gay men need for effective HIV prevention. I'm going to focus on 4 main areas. First, men need to be able to access the prevention technology or method. They need HIV education that increases their knowledge and speaks to their motivations for preventing transmission. And to enable these things, there needs to be a supportive institutional environment and a foundation of strong research. So starting with access. It's clear that this operates at many levels and includes several components. I'll just go through these in turn. For new technologies involving pharmaceuticals or medical devices, regulatory approvals have become, in many places, a significant barrier to access. PrEP is still only officially approved by the governments of less than 15 countries, and home HIV testing is only officially approved in a handful. There is no doubt that the cost and time associated with approvals needs to be improved. And there's also an issue of political will that operates here, such as in the UK, where PrEP funding has become a bit of a political football going between the local health authorities and the Public Health England. And guidelines also have an important role to play here in achieving greater access. So currently, 44% of the world's HIV positive population live in countries where ART is available for all, regardless of CD4 count. And they're the countries there. And this is up from only 14% last year. So this is actually great news, but there's still a fair way to go. Briefly on affordability, it's pretty obvious, but if we want to see the many and varied HIV prevention tools be used by gay men, then they must be affordable for gay men. For example, the places with some of the highest or best HIV treatment cascades globally, such as New South Wales, Sweden and the UK, are places where ART is accessible for free or very low cost. And furthermore, the affordability of PrEP is of particular concern, given that as of late 2016, only a couple of countries provided government-subsidised access to PrEP. In the US, we know that people can access PrEP through private health insurance, but that's not accessible for everybody and it can be very complicated. And in lower to middle income countries, they sometimes have access to generic medicines, such as here in Thailand, at relatively low cost. However, cost may still be an issue for some gay men. And for those without access to subsidised PrEP or generic medicines, the price tag of up to around $10,000 a year is completely prohibitive. So currently in most places, PrEP is only affordable due to the demonstration trials, which provide free or very low cost access, and usually only to a very small number of people. So the next thing is convenience. Even when new technologies are approved and available at an affordable price, they must be convenient for gay men to access. In a public health emergency such as the global HIV epidemic in gay men, the onus is on us to ensure that access to HIV prevention is convenient. While there's been some research into this, most research is focused on characteristics of patients, almost kind of problematising the patient and blaming the patient for not coming in to access services. And very little research is really focused on the structural factors that prevent people from presenting. And this issue has become more important recently as the role of clinics in HIV prevention is only increasing due to the emergence of biomedical prevention. Research has consistently highlighted issues such as the difficulties in booking appointments at clinics and the time that appointments can take in the clinic. So our services must be realigned so that gay men and others do not need to take significant amount of time off work, for example, to be able to attend a clinic appointment. And Dr. Nitya talked about some great examples there. In terms of accessing PEP, there have been many reports in the literature for some time about how difficult it can be for men to acquire PEP close to the time of exposure. And I'm aware that some people around the world are thinking creatively and a little bit radically about this. So could we perhaps consider just distributing PEP starter packs to community-based organisations or even networks of peers? Could we have PEP vending machines or online ordering systems that get the PEP to the person within a maximum of 24 hours? So I think we need to be thinking creatively about some of these issues. And lastly, on convenience, it also applies to other settings too. In most places, or in many places in the world, sex on premises venues or saunas do not operate legally as such. And so what that means is that men come into the sauna and they're not really provided with any condoms or lubricant, or maybe just a very limited supply. And this is really unacceptable. If we want HIV prevention to be used, we need it to be at arm's reach. So a lot of work is happening on testing, and it's really good to see that lots of campaigns are trying to encourage gay men to access testing. But testing is one of the main areas that can be really inconvenient for gay men, or any population really. So Nitya has actually foreshadowed a lot of these options, but it is good to see that now there are several different types of testing options that are available. Many cities around the world are now starting to see community-based testing facilities where the testing is run by gay male peers. So for example, in Sydney, after only just a couple of years of operation, our community-based testing site is now diagnosing 13% of all the HIV diagnoses in the state. And Magnet in San Francisco is now diagnosing the most HIV cases among gay men in San Francisco. Several places are now offering home sampling, and in the UK they've had the experience of this being quite effective to reach difficult-to-reach populations. And meanwhile, 2 randomised controlled trials now have shown that access to home HIV testing increases testing frequency among gay men by about 2 times. So access to home testing must be made more widely available if we are to reach the testing levels required. And there have been some really interesting and exciting innovative approaches, such as the one that Dr. Nithya presented around the online supervised home testing. And I think we need, again, to see more creative ideas like that. And of course, if we want gay men to access prevention programs and services, they must be able to do so without experiencing stigma and discrimination. Male-to-male sex is still criminalised in many parts of the world, and this typically correlates with the general societal attitudes towards homosexuality. In a recent global analysis published just last year, researchers showed significant associations between arrest or convictions for being MSM and lower access to STI services, condoms, and medical care more generally. But it doesn't have to be such overt forms of stigma to cause problems, and this of course can play out in our health services or programs, where gay men can experience negative attitudes from health workers, inappropriate advice, and indeed overt discrimination. Where possible, services really need to explicitly advertise that they are gay-friendly, or the gay specific, and it's not enough just to simply assume that the gay community already know this. And of course, such statements must be backed up by internal work to make sure that services are indeed truly gay friendly. So I want to focus now on HIV education. It needs to be recognised that knowledge is not enough. It's not sufficient to create behavioural change, but basic knowledge is an important precursor, especially about new and emerging technologies such as treatment as prevention and PrEP. In many settings, it's also important that governments and organisations take up the broader challenge of increasing general health literacy among gay men and other populations. So gay community organisations around the world have learned a lot about the best ways to do HIV education in our communities. Some of the principles of best practice include the idea of culturally appropriate messaging. So this is where HIV education must be locally relevant. You can't just take necessarily one intervention that worked one place and just wholesale move it into another. It should be peer-based, it should use colloquial and appropriate language that makes sense to gay communities, and of course it needs to be appealing. Importantly, it also needs to be targeted. The gay community is not homogenous, it comprises all sorts of different subgroups and networks, and in many cases such subgroups need to be provided with their own peer-based educational efforts. Secondly, HIV education should use multiple modes to deliver and reinforce HIV prevention messages, and these can include some of the examples on the screen there, but not just limited to those. And thirdly, health promotion literature in many fields of health has shown that fear-based messaging is typically ineffective and can serve to increasingly already stigmatised communities. So it's better to use positive, motivating messages rather than fear-based messages. So in this slide, I just want to show how rapidly and dramatically HIV knowledge in gay communities can change. This is an example from Sydney, showing that just 3 years ago, only 1/3 of gay men believed in the concept of treatment as prevention. And due to the widespread and sustained community education on this issue, 83% of men now know that it's an effective HIV prevention tool. And I expect that even this year, that'll go up even more. So most HIV education around the world essentially stops at knowledge. It simply aims to provide gay men with information. And I'd argue that while knowledge is important, it's not enough, and that HIV education should include explicit references to the reasons why gay men should be committed to HIV prevention. For some men, the best approach will be to talk about personal benefits of prevention, whereas for others, it may be about finding ways to decrease personal barriers to prevention, such as the fears they hold, or perhaps dealing with misconceptions about risk. And this is one that we've seen in our setting, that many men who are actually engaging in very high-risk sexual behaviour don't actually perceive that behaviour to be high risk at the time of the event. And so we've really got to do more education on encouraging people to understand, genuinely understand and accurately the risk. Lastly, an important motivating element in many successful HIV prevention campaigns is that they incorporate a focus on collective action rather than just individual action. And this has been particularly true over the last few years, where several cities around the world, such as Sydney, Vancouver, San Francisco, have adopted large-scale community mobilisation campaigns about ending HIV transmission. And this approach appeals to the reasons for HIV prevention that go beyond the individual and are more about the broader gay community or the importance of protecting loved ones and partners. And importantly, this approach also highlights that HIV prevention is a shared responsibility between HIV negative and HIV positive men, which has never been more true than now that we have treatment as prevention and PrEP. So before I move on, I want to pause here to reflect on an example of HIV prevention education with gay men from our context. So many organisations around the world create and implement fantastic campaigns, but the campaign reach is really small, or it just uses one mode of education. And so what that means is that most gay men in that location are never going to see the campaign, or if they do, they're only going to see it once. So in my view, what's needed is consistent, multimodal, multi-location HIV prevention messaging that is reinforced over time and that's targeted to both the general gay community and specific subgroups within that community. And to give you a practical example of this, I want to look at the Ending HIV campaign that's been implemented in New South Wales over the last few years by the largest community-based organisation for gay men in Australia, ACON. And I'll be focusing this on just a particular period of time during the year. I'm sure most of you will have heard of the annual Mardi Gras festival, which happens coming up soon. This is a time that many of our organisations use to really push HIV prevention messages because it's a very active and exciting time in the community. And it's almost impossible during this time for a person who's connected to the community or who is sexually active to avoid seeing the HIV prevention messages. So the images that I'm going to show you all come from this one campaign, not necessarily from the same year, but over several years of the campaign. Just to give you an idea of what it's like for a gay man to be living in Sydney during the month of Mardi Gras. So the first thing is when he attends the Mardi Gras Day Festival, one of the biggest annual gay community events held in Sydney, attended by over 30,000 people. He'll be offered condoms, fans, fake tattoos, he'll be asked to pose in photos, to be posted to Instagram and Facebook, and he'll be provided with sexual health messaging. On the night of the Mardi Gras parade itself, the campaign will be further reinforced. When he walks into any gay bar or club in the city, there'll be safe sex packs with condoms and lubricant branded with the campaign imagery. There'll be campaign coasters sitting on every table. When he goes to the toilets, there'll be a poster on the back of every toilet door and above every single urinal. At certain times during the month, groups of volunteers wearing campaign t-shirts will go into the bars and interact with community members. And if there are performances, such as by drag queens, they'll often promote the message too. If he goes to any gay dance party during the Mardi Gras season, he'll be greeted by volunteers at the door who hand him condoms. There'll be posters and other collateral throughout the venue. And there'll be teams of volunteers on hand throughout the night to ensure any questions can be answered. At some events, there'll even be the opportunity to access mobile rapid testing. And every time he goes to see a film as part of the Mardi Gras Film Festival, which is a huge queer film festival, he'll see a video promoting the campaign before every single movie. If he attends any peer education workshops during the month, the volunteer facilitators will make sure that the usual content of the workshop is tweaked so it reinforces the campaign message. If he walks around the city, he'll see campaigns on bus shelters, at train stations, on banners running down the street, on large billboards or posters in the suburbs where concentrations of gay men live, or where there are a large number of gay social or sexual venues. Specific times during the month, there'll be what we call activations happening in various locations where condoms, information and other paraphernalia are handed out to the community. He may see a plethora of pink at Sydney's famous Bondi Beach. He may be asked to pose for a photo at Taylor Square, which is in our gay district. Or if he goes to the centre of the city, he might see our giant pink condom in our main city park. If he goes to any of the sexual health clinics or GP clinics in the area, he'll see more posters and he'll see more paraphernalia. If he goes to a sex on premises venue or sauna, he'll see campaign posters on the walls throughout the venue and in the toilets. Every single area in those venues will have condoms and lubricant at arm's reach. We know this because every single sex venue in Sydney is signed up to a voluntary code of conduct specifying that they must provide condoms and lube in every room. And these venues are assessed regularly against this code of conduct. At the busiest times of the week, there'll also be volunteer peer educators in the venues that can answer their questions. If he opens up any of our free gay newspapers that he picks up on the street, there'll be full-page advertisements and articles detailing more information. Any gay online media source will also be running advertisements and articles which you can click on to find further information. If he's on Facebook, he'll see various types of advertisements or promoting the campaign, as well as many viral videos or images being shared by friends. If he Googles anything about HIV during this period, the first thing that will come up is the campaign website. When he uses the various sexual networking apps like Grindr or Jacked, he'll see advertisements about the campaign, as well as sometimes running into a peer educator in that space. So during a campaign period like this, you can see how it would be very difficult for any community-connected gay man not to see the campaign, and indeed not to see it multiple times in multiple modes and in multiple places. Importantly, the campaign won't be the same everywhere that he sees it. On bus shelters or out in public, It'll be sort of a safe and uncontroversial message that gets presented, but in more private gay spaces it'll be more sexually explicit and more targeted. And there'll be ranges of types of gay men represented, and the content will focus on the specific concerns of that sub-community. Of course, it's not perfect. There are still men who might miss out on the campaign, and there's always the issue of whether campaigns translate fully into action, of course. But the community organisations are constantly working to increase the scope and the reach of the campaigns. And indeed, the approach taken over the last few years in Sydney has taken decades to achieve, often involving challenging partnership work with a very diverse range of stakeholders. And clearly this kind of approach relies on very strong, well-funded, community-controlled organisations. So that segues nicely into this supportive institutional environment section. Globally and in different regions, the HIV prevention response for gay men and other MSM is chronically underfunded. Despite having higher prevalence and incidence in the general population, as shown before, HIV prevention spending on MSM is typically very low. For example, here this chart shows the proportion of prevention spending in MSM in blue compared to the others in red in lower to middle income countries. In Asia, analysis by the Asia Pacific Coalition on Male Sexual Health demonstrated only 3 countries spent an amount on MSM proportional to the MSM making up HIV diagnoses. And a similar story is playing out in Latin America, where only Peru was spending a proportional amount. So it's been noted in the literature that funding for MSM and other key populations in most lower to middle income countries comes almost exclusively from international donors, and that national governments can be unwilling to prioritise HIV prevention for MSM due to the same societal stigma discussed earlier. And perversely, stigma can also lead to a lack of funding for solid research on local MSM epidemics, thus leading to poor awareness among policymakers of the seriousness of the problem. So it can become a bit of a catch-22. So effective HIV prevention requires strong, well-funded and courageous community-controlled organisations. These are responses that are initiated, designed and implemented by the community. They are highly responsive to the needs of their communities and they conduct their work in partnership with mainstream services. Importantly, the primary elements setting community organisations apart from other NGOs is that they depend on their community for authority, which means that they are more trusted. Some of the benefits of community-controlled organisations being central to the response is that they're embedded in communities and have deeper understandings of the local issues, local epidemiology and effective, acceptable solutions. They are able to initiate rapid, adaptable and flexible responses to emerging issues. And they are highly cost-effective due to the value of the intangible assets that they can mobilise, such as volunteers or unpaid media. They're the best experts in the content and delivery of culturally appropriate HIV education. And finally, they have permissions to do certain things that a government agency, for example, could never do politically. However, these benefits of community-controlled organisations can only be realised if there's genuine partnership between the stakeholders in the HIV response. Community needs to be invited to the table. And I think that is happening a little bit more around the world. But once they're at the table, and this is the onus comes back onto the community, these organisations must make themselves indispensable to the response so they can't be ignored. So finally, just very briefly, I've only got a couple of minutes left, so I just want to talk about how research has been central to HIV prevention, and gay men need good quality research in all the countries that we work in to be able to continue to support HIV prevention. A major problem that has been ongoing for decades is a lack of good quality epidemiological and behavioural data on MSM epidemics in many places. For example, in 2013 I conducted a review of all the published academic articles on MSM in the Asia Pacific region, and although there was a clear trend of increased research, such as shown here by the number of articles published per year, nearly 3/4 of the articles focused on just 5 countries. Furthermore, there were no published epidemiological articles on MSM in any Pacific Island country, and several Asian countries had no articles, which also included Cambodia and the Philippines. In many countries, there were just a very small number of articles published, and that included Indonesia, which is obviously the fourth largest country in the world by population, and which is experiencing an uncontrolled epidemic amongst MSM. So research into understanding MSM epidemics and their local drivers is clearly a critical priority. An important challenge for research in the combination prevention environment is to develop better measures of risk in the gay community, given that we now know that much condomless sex can be safe. So to be able to adequately determine whether sex has been truly high risk, many factors need to be understood. We can't just ask about condoms anymore. We need to know about condom use, the type of partner, sexual positioning, testing, disclosure of status within sexual relationships, PrEP use, and viral load. And different places in the world are going to come up with different solutions to this. But in any case, the take-home message here is that we just can't use any condomless intercourse anymore as the primary measure of HIV risk. We also need more and better quality research into the structural issues facing HIV prevention, as well as better implementation science that evaluates the impacts of packages of HIV interventions rather than just viewing them in isolation. So to conclude, the global HIV epidemic among gay men and other MSM is worsening, and in some places rapidly. But we have the prevention tools that we need, as we've heard about already this morning. For HIV prevention efforts to be effective, gay men need access to prevention tools, appropriate peer-based HIV education, funding for prevention programs and community-controlled organisations, and good research on local epidemics and behaviours. And finally, it is absolutely essential that community be central to all of these aspects of HIV prevention. So thanks very much for your attention.
Thank you very much, Ben. In terms of filling up the roadmap how to end HIV/AIDS among MSM and transgenders. So it's very useful because, you know, I don't think that any country will not have a problem of HIV infections among MSM. So either you still have a very low prevalence among MSM, I can predict that within the next 5 years, any country will also have a problem with HIV among MSM. So take care of your own country and then try to do the best of that. So thank you very much, our speaker this morning. Now it's time to go outside to grab your lunch box and then come back in about 10 minutes. We will start a lunch symposium here. Thank you.